Are you looking to learn about myofascial pain and endometriosis? Are you having ongoing pain after excision of endometriosis? Then tune into this video. It's a great place to learn about the pelvic floor, about trigger points, about trigger point injections, Botox, and more. All brought to you by the Endometriosis Summit and Dr. Dana McKee of the Mayo Clinic. Tune in. This is a fabulous Endo Summit Live. Good evening, Endometriosis Summit crowd, and welcome to this very special edition of Endo Summit Live. We are here tonight talking about certainly one of my favorite subjects, which is myofascial pain and endometriosis. Please welcome from the Mayo Clinic, Dr. Dana McKee. Doctor, can you introduce yourself for us?
Yes, absolutely. Thank you so much, Sally, for that introduction, and thank you for the opportunity to be here. I am Dana McKee, and I am currently a fellow in minimally invasive gynecologic surgery at Mayo Clinic in Arizona. I did my OBGYN residency training at Duke, and I'm excited to be here to present to you myofascial pelvic pain. So,
We are so excited to have you. And one thing that Dr. McKee and I were discussing was that when I started working in endometriosis as a physical therapist about 15, 20 years ago, there was one other doctor talking about that myofascial pain, which was Dr. Maurice Chung. And now, even though Dr. Chung is our buddy and he joined us for the endometriosis summit, myofascial pain has taken over the world because we know that endometriosis may be about good excision done right, but there are so many other generators for pain. So take it away, Dr. McKee.
perfect. Thank you. All right. All right. Sally, can you see my screen? Can I get a thumbs up? Perfect. All right. So we have no financial disclosures, but I will say we will be discussing the off-label use of medications, primarily diazepam and botulinum toxin. The objectives of this talk are to understand the role of myofascial pelvic pain as a contributor to chronic pelvic pain, to illustrate relevant anatomy and physical exam techniques for proper assessment of myofascial pelvic pain, and to identify and describe the various treatment options for patients with myofascial pelvic pain. And I just want to start with a patient case presentation. We have a 38-year-old female with a long-standing history of pelvic pain, worse on the left side. For several years, she had dysmenorrhea or pain with her menstrual cycles, but now has progressed to having pain approximately 3 weeks out of each month. She underwent a hysterectomy and excision of endometriosis with her OBGYN with confirmed endometriosis on the pathology report. Since then, a patient continues to report near daily pelvic pain and lower urinary tract symptoms, including dysuria and urgency and frequency. She's been tested for a urinary tract infection, but that's been negative. As you can see in these tables, the differential diagnosis for pelvic pain is quite long. Sources of pain can be from various organ systems, including gynecologic, urologic, GI, musculoskeletal, or neurologic. Even when a diagnosis is found, treatment of the cause often doesn't elicit the expected results. This can be due to the fact that pain can have multiple presentations and often carries a multifactorial etiology. Our talk will focus on a musculoskeletal component of pelvic pain called pelvic floor tension myalgia or myofascial pelvic pain syndrome. So what is myofascial pelvic pain syndrome? This is a musculoskeletal pain disorder characterized by contracted bands of skeletal muscles that contain discrete painful nodules known as trigger points. Trigger points are tender to palpation and with palpation can produce sensory, motor, and rarely at times symptoms like tachycardia, sweating, or tearing. Trigger points are thought to be caused by an acute muscle trauma or repetitive microtrauma. In a pelvic pain clinic, the prevalence of musculoskeletal pain is estimated to be as high as 75% and is often unrecognized or misdiagnosed. Pelvic floor muscles contribute to chronic pelvic pain in women as both the primary pain generator and as a compensatory contributor, meaning that pain may be a result of inherent musculoskeletal causes in the pelvic floor muscles, or it may occur as a functional adaptation to other disorders within the pelvis. So this creates a chicken and egg situation where we may not know which came first. For example, it's common to see pelvic floor dysfunction arise in patients with visceral pelvic diseases such as endometriosis or irritable bowel syndrome. In one study, women with deep infiltrative endometriosis had higher rates of pelvic floor muscle hypertonia compared with the control group. And in another study, myofascial pain and pelvic floor dysfunction were present in 85% of patients with bladder pain syndrome. This is an algorithm that Dr. Hibner developed, outlining many, if not all, of the potential causes of pelvic pain. And ultimately, what it shows is that all roads can lead to pelvic floor tension myalgia or myofascial pelvic pain. Part of the reason chronic pelvic pain can be so difficult to treat is because many patients have multiple diagnoses. Failure to identify and treat myofascial disorders may exacerbate pain symptoms related to coexisting conditions. That said, a thorough workup for visceral pathology should be performed prior to assuming that myofascial pain is the primary source. So in other words, assume that myofascial pelvic pain is the downstream effect until a workup has been performed to rule out other causes. So what are the symptoms of myofascial pelvic pain? The obvious way that it might present is with local pain in the pelvis or abdomen, but it can also present with a variety of other symptoms that overlap with other disorders. This includes urinary symptoms such as urgency or overactive bladder, frequency, dysuria or pain with urination, or hesitancy. It may present as vulvar or vaginal burning, itching, or pain with intercourse. In fact, a red flag is if a woman reports a history of prolonged discomfort for several hours or days after intercourse. This suggests musculoskeletal pain and is similar to a post-exertion muscle soreness that you might experience after going to the gym. It can present as abdominal fullness or bloating, rectal fullness, constipation, or pain with defecation. It may feel like spasms of the rectum, vagina, or bladder. And when it comes to these trigger points in the pelvic floor, these can often cause referred pain to the vagina, the vulva, the rectum, the bladder, but also to more distant areas such as the buttocks, the low back, or lower abdomen. In fact, it is fairly common for pain to be referred to the lower abdomen, resulting in possible confusion between musculoskeletal, gynecologic, or GI sources of pain. Symptoms of myofascial pain can be continuous or episodic, and they may be acute in onset or chronic. Additionally, the pain is often worsened with specific positions or activities and improved or alleviated by others. Any of these symptoms, in the absence of objective findings like positive urine or vaginal cultures for infection, should prompt evaluation for myofascial pain. The exact cause of myofascial pain is not entirely clear, but there are certain risk factors that may predispose to myofascial pain, including things like poor posture or orthopedic pathology, acute or repetitive trauma to the pelvic floor from sports injuries or from a prior obstetric delivery, sexual trauma, post-traumatic stress disorder, or previous surgeries may also lead to myofascial pelvic pain. It can also develop secondary to inflammatory conditions such as irritable bowel syndrome, endometriosis, as well as other visceral causes. Before we get into the physical exam components performed by the clinician, let's go over some important anatomic structures. The pelvic floor is composed of muscles, ligaments, and fascia that act as a sling to support the bladder, reproductive organs, and the rectum. The pelvis is composed of a bony ring, which serves as a site for multiple cartilage, ligament, and tendon attachments. In the posterior pelvis, we have the sacroiliac joints, indicated by the red arrows, and anteriorly is the pubic symphysis. These joints are stabilized by ligaments, including the sacroiliac ligament, the sacrotuberous ligament, and sacrospinous ligament. Moving on to the muscles, the pelvic floor muscles are 70% slow twitch striated skeletal muscle and provide nearly constant muscle tone to the pelvic floor. The superficial pelvic floor muscles, also known as the urogenital diaphragm, include the bulbocavernosus muscle, the ischiocavernosus muscle, and the superficial transverse perineal muscle. The perineal body is the convergence of the superficial pelvic muscles and sphincters and provides support to the pelvic floor. The deep pelvic floor muscles that line the inner walls of the pelvis are the levator ani and coccygeus, which along with the endopelvic fascia comprise the pelvic diaphragm. The levator ani is a muscle group composed of 3 muscles, puborectalis, pubococcygeus, and iliococcygeus. And these muscles maintain pelvic floor tone and protect the connective tissue from excess load. Of note, it can be difficult to accurately distinguish these individual muscles on a digital vaginal exam. Lining the lateral walls of the pelvis are the piriformis muscle and the obturator internus, and these work to externally rotate the femur. Here's a view posteriorly from the back of the piriformis coccygeus and obturator internus muscles. For the physical exam in a patient with pelvic pain, it's often helpful to first observe the patient's behavior. For example, is the patient standing while speaking with you, or does she sit up on one buttock due to discomfort from sitting directly on the pelvic floor? What is her posture like? Is she hunched? Is the patient weight-bearing on one leg more than the other? Does she exhibit pain with walking or with certain movements? And prior to getting into this specific assessment for myofascial pelvic pain, there are a few exam maneuvers the clinician can do to assess for alternative pathology, which may indicate need for referral to another provider. You can start by palpating the paraspinous muscles from the cervical spine all the way down. Diffuse tenderness throughout may indicate a systemic pain syndrome, such as fibromyalgia, as opposed to solely pelvic pain. Carnet's test is useful to assess abdominal wall myofascial involvement. A positive sign is when tenderness is increased when the abdominal muscles are tensed or contracted. Tenderness that is exacerbated by muscular contraction is more likely to be due to pathology within the abdominal wall as opposed to visceral pain. Rotating the shoulders left or right while contracting the abdominal muscles can also help isolate specific muscles for evaluation of trigger points. To check for pathology at the hip joint, you can do the Faber test, which stands for femoral abduction external rotation. As demonstrated in this picture, the hip is flexed and abducted with the lateral ankle resting on the contralateral thigh proximal to the knee. While stabilizing the opposite side of the pelvis at the hip, external rotation and abduction are applied to the bended knee. A positive test is marked by reproducible pain with passive external hip rotation. The P4 test, which is the posterior pelvic pain provocation test, is used to identify pathology of the sacroiliac joint. With the patient supine, the hip is flexed to 90 degrees with bended knee. The examiner applies pressure along the length of the femur. The test is positive if the pain is reproduced with this maneuver. In 2018, Meister et al. Developed a simple reproducible exam to screen for pelvic floor myofascial pain. The exam includes assessment of both external and internal anatomic sites, and these are the steps that they recommend. Prior to beginning the exam, it's important to let the patient know what to expect, including the internal assessment of pelvic floor muscles and the possibility of exacerbating their pelvic pain with this exam. With the patient seated on the table and feet resting on the floor, Start with palpation of the SI joint to assess for tenderness in this area. Next, reposition the patient to lithotomy position with their feet in stirrups and ensure the hips are neutral without excessive flexion, abduction, or external rotation. Then palpate the medial edge of the ASIS for tenderness, which is the origin of the iliacus muscle. Following that, you can palpate the cephalad edge of the pubic symphysis, which is the origin of the rectus abdominis muscle. Now we move on to palpation of the internal muscles, and prior to doing this, you can demonstrate to the patient the amount of pressure you will apply by first applying that same amount of pressure to the mid-thigh with your finger. Internal palpation is performed with the index finger of the dominant hand. You should palpate once in the center of the muscle belly, then move in a sweeping motion along the length of the muscle in the orientation of the muscle fibers. For convenience and repetition, they recommend performing the exam in a counterclockwise direction, starting with the right obturator internus, right levator ani, left levator ani, and then left obturator internus. I'm going to just briefly switch over my screen here to a video. This is a video of a cadaver dissection that will help us to really understand what these pelvic floor muscles look like. So here the bladder is reflected, and with a finger in the vagina, I'm palpating the levator ani muscles, starting most proximal and moving deeper. There I'm palpating the obturator internus muscle, which is more superior and lateral. And lastly, I'm palpating the coccygeus, which is the most proximal muscle of the pelvic floor. Here we are focusing in on the obturator internus, looking specifically on the right side. This muscle can be isolated by having the patient abduct the ipsilateral knee against resistance, such as your non-examining hand. So here we're zoomed in, and if the provider is having a hard time locating the obturator internus, having the patient abduct their knee against resistance can help that muscle to contract and help the muscle to be isolated. So back to the presentation. When I have diagnosed a patient with myofascial pelvic pain and I'm explaining to them the diagnosis, I found that this concept can be confusing. So how do we explain this diagnosis to patients? First, I like to explain to the patient that just like the arms and legs are made of muscles, the pelvis is also made of and supported by muscles. And what they are experiencing is like a Charlie horse of the pelvic muscles. And while we may not be able to pinpoint the patient's exact cause or risk factors that they have, stress is certainly an important trigger. Stress might be in the form of recent surgery or injury, life stressors like in the process of changing jobs or studying for an important exam, but also things like violence or abuse can trigger a pelvic floor muscle spasm. And as I discussed earlier, having coexisting pelvic pain conditions such as endometriosis can contribute to muscle spasm and pain. A great example is thinking about a dog tucking its tail between its legs. This is a stressed and frightened dog, and when that occurs, the response is to contract or spasm the pelvic floor muscles. And as humans, we do the same thing when we are under stress. And if this is a repeated occurrence over time, trigger points can develop. Trigger points, once formed, can be activated again in the future by a seemingly insignificant physical or emotional stressor. Another thing to consider with this condition is the importance of good sleep. Our muscles relax during the REM phase of sleep, so patients who aren't sleeping well and don't enter the REM phase of sleep as they should may not relax their muscles overnight. So treatment may involve improving quality of sleep. Lastly, unlike stretching out your calf or your triceps muscle, one cannot stretch their own pelvic floor muscles. So back to our patient. So as a recap, we know she has had endometriosis from her prior surgery, which was removed, and she also had a hysterectomy. But she continues to have near daily pelvic pain with lower urinary tract symptoms. So we performed a physical exam, which demonstrated spasm and tenderness of the bilateral levator ani pelvic floor muscles. We explained the concern for myofascial pelvic pain and told her that she is unable to stretch her own pelvic floor muscles. So what can she do? Well, this brings us to our first treatment option, which is pelvic floor physical therapy. When it comes to myofascial pelvic pain, pelvic floor physical therapy is first-line treatment and arguably the most important treatment option available. The goals of therapy are to restore muscle imbalance, improve function, and reduce pain. Pelvic floor physical therapy may include the use of dilators, relaxation or breathing exercises, posture correction, internal manual therapy, as well as biofeedback. Manual therapy includes transvaginal trigger point release, as well as connective and scar tissue mobilization. Typically, patients undergo 1 to 2 sessions per week for a total of 8 to 12 sessions, but this could be highly variable and is tailored to the patient's needs. Patients with chronic pelvic pain, for example, may need ongoing therapy for several months, as well as future maintenance sessions. So what is the evidence for pelvic floor physical therapy? Well, pelvic floor PT has not been evaluated rigorously, and there are currently no gold standards for recommended modalities, therapy session length, frequency, or duration, but initial studies have been promising. Dr. Frank Tu et al. Performed a 2005 systematic review to evaluate the use of manual techniques to alleviate musculoskeletal pelvic pain. And although there was wide variation in pelvic floor physical therapy techniques, the authors concluded that 59 to 80% of women reported improvement in their pelvic pain with PT. A non-randomized study of 21 women with pelvic floor myofascial disorder showed that patients had a statistically significant improvement in pain scores after 5 weeks of twice-weekly intravaginal myofascial release and for up to 4.5 months after treatment. Data from a multi-center randomized trial supports pelvic floor physical therapy for the treatment of chronic pelvic pain in patients with urologic symptoms. In this trial, the positive responder rate was significantly higher with manual myofascial physical therapy compared with traditional therapeutic massage. And most recently, a study published in 2021 included 474 women treated with pelvic floor physical therapy for multiple pelvic complaints, including pain. They reported clinically significant improvement on standardized pelvic floor distress questionnaires after an average of 9.3 treatment sessions. For patients, there may be discomfort surrounding the use of intravaginal exams and manual therapy during these sessions, and patients may also have time restrictions or barriers which might prevent them from attending the multiple sessions that are needed. What I want to stress is pelvic floor physical therapy is truly a low-risk option with a high success rate, and patient education by the physician and staff is important in order to properly relay the treatment goals and expectations for these sessions. And just so everyone's aware, there is an online PT locator by the American Physical Therapy Association, which has a listing of physical therapists in your area that specialize in the management of pelvic floor dysfunction. Next, we will talk briefly about dry needling. Dry needling without injection into the myofascial trigger points is thought to desensitize the trigger point and decrease muscle spasm, an effect commonly associated with acupuncture. Dry needling may be performed by the physician or a physical therapist just prior to a pelvic floor PT session as an adjunctive therapy. Data regarding the use of this modality is scarce. A systematic review in 2007 evaluating the evidence on dry needling without injection found needling was not significantly superior to placebo. So our patient underwent multiple sessions of pelvic floor PT and reports that she had approximately a 50% reduction in her pelvic pain, which is great. But she would like to know if there are other treatment options that may be useful to try now or in the future if her pain worsens. Our next treatment tier includes pharmacologic agents. NSAIDs are often used in the treatment of chronic pelvic pain as it's an easy option given they are readily available and don't require a prescription. But data supporting NSAIDs specifically for myofascial pelvic pain are lacking. They may be useful for mild symptoms, but are likely of little to no benefit for more severe myofascial pelvic pain symptoms or during an acute flare. It's important also to consider adverse effects of these medications, including things like GI upset. Neuropathic pain medications can be effective, especially when there is a neurogenic component to the patient's pelvic pain. These medications include things like gabapentin or pregabalin, also known as Lyrica, SNRIs, and tricyclic antidepressants. The treatment approach using these medications is really individualized and depends on the efficacy and side effects for the individual patient. These medications are often changed or used in different combinations or have dosing adjustments. So it's often useful in these situations to see a neurologist or a pain specialist when there is a need for multimodal or multi-drug therapies. So muscle relaxants, cyclobenzaprine or Flexeril is a centrally acting skeletal muscle relaxant, and it has demonstrated efficacy in the treatment of fibromyalgia and muscle spasm. Few studies, however, have specifically examined the effect of cyclobenzaprine on myofascial pain, and a Cochrane review shows insufficient evidence to support its use in myofascial pain. We feel it is still reasonable to trial the medication for women with myofascial pelvic pain, often in combination with other treatments such as physical therapy. Typically, the patient will be started with 5 milligrams at bedtime, given that sleepiness is a common side effect, but this dose can be increased to 10 milligrams if needed. Next, we'll look at vaginal diazepam suppositories or vaginal Valium, and these may also reduce pain and muscle spasm, although the data for this are limited and conflicting. Holland et al. Performed a 2019 double-blind randomized trial comparing the use of 10 milligrams of vaginal Valium versus placebo for treatment of pelvic floor muscle spasm. They found no significant differences in pain scores between the groups after 4 weeks. Similarly, Crisp et al. Also performed a randomized controlled trial, which showed no subjective improvement or improvement in resting pelvic floor electromyography in participants receiving vaginal diazepam compared with placebo. These participants also received the treatment for 4 weeks. Evidence in support of vaginal diazepam includes a small prospective clinical study of 21 women with pelvic floor dysfunction and urogenital pain. Patients received 1 month of daily vaginal diazepam. 62% reported moderately or markedly improved pain, and levator examination pain scores were also significantly improved. Finally, Rogalski et al. Performed a retrospective chart review, which showed that patients who received vaginal diazepam as an adjunct to pelvic floor physical therapy reported improvement in pain and sexual function with the suppository use. In terms of dosing, patients can start with 5 milligrams or 10 milligrams nightly. The majority of women do not experience adverse side effects with vaginal diazepam, but a small proportion may have drowsiness. Depending on the presence of this side effect, patients can increase the dose up to 3 times daily. Vaginal Valium may be best utilized prior to sexual intercourse or pelvic floor physical therapy to help reduce pain. Besides the vaginal Valium, compounding pharmacies can produce vaginal suppositories with additional medications. For patients with a neuropathic pain component, it may be useful to add gabapentin. Other combinations include medications like baclofen or even ketamine, but there are no studies on any of these, and in our practice, we do not routinely offer these combinations unless patients specifically ask or have had previous treatment benefit with these. In terms of topical lidocaine, this can also be used for treatment if penetrative dyspareunia is involved. This medication is especially useful when used prior to physical therapy for patients that have trouble tolerating the internal myofascial release of the pelvic floor muscles. Emla cream and topical ointments are non-alcohol based and are preferred given that lidocaine gel has the potential to cause burning, particularly in patients who also may have vulvodynia or atrophy. Back to our patient. For her residual pain, we tried 2 weeks of nightly vaginal diazepam suppositories. Unfortunately, she did not have any additional relief from this treatment option, so we counseled her on the option of trigger point injections. The next treatment modality that we are going to discuss are the trigger point injections, and these are typically not used as first-line therapy or as monotherapy, but are found to be more beneficial when used along with physical therapy, medications, or behavioral therapy. Injections typically consist of a local anesthetic with or without a steroid, and the proposed mechanism of action of trigger point injections includes disruption of reflex arcs within skeletal muscles, release of endorphins, and mechanical changes in abnormally contracted muscle fibers. There's good evidence supporting the use of trigger point injections. Zurobe et al. Performed a pilot randomized trial of 29 women comparing pelvic floor physical therapy versus trigger point injections. For the trigger point injections, they used a combination of local anesthetic and steroid. Both groups reported improvement in pain. Interestingly, the trigger point injection group had faster improvement at 4.4 weeks compared to 7.3 weeks for the physical therapy group. But while both groups also reported improvement in sexual function, the physical therapy group demonstrated greater improvement in that regard. Langford et al. Performed a prospective observational study of 18 women who underwent pelvic floor muscle trigger point injections. At the 3-month follow-up, 13 of the patients had significant improvement after the 1 injection, and 6 of the patients were completely pain-free. A retrospective chart review of 75 patients who underwent trigger point injections for pelvic floor muscle spasm showed improvement in pain scores in 63% of patients after 1 injection. 27% of patients needed repeat trigger point injections with the mean time between injections of 2.8 months. 16% of patients ultimately needed to proceed with Botox injections. And finally, another retrospective chart review was conducted at Mayo Clinic, Florida, of 68 female patients who underwent pelvic floor trigger point injections. They demonstrated improvement in VAS pain scores for 65% of patients. The median difference between scores in patients who improved was 3. Of note, 25% of patients required repeat injections with pain relief for an average of 2.2 months between injections. In terms of Botox injections, for patients with refractory pelvic floor myofascial pain that is not responsive to the treatments previously discussed, botulinum toxin or Botox injections may be an appropriate next step. Botulinum toxin is a potent neurotoxin produced by the bacterium Clostridium botulinum. The toxin is the most poisonous naturally occurring substance known. In terms of mechanism of action, this toxin works by blocking the release of acetylcholine from the presynaptic neuron at the neuromuscular junction, leading to muscle paralysis. There are 5 known subtypes of exotoxin categorized A to E. Types A and B are currently the only commercially available subtypes. The clinical effect of the toxin is dose-related, and these effects decline over time as the target muscle cells recover and return to normal contractility. Botox has been described in the treatment of other pain conditions, including muscle spasticity, dystonia, and headaches, but data is limited specifically regarding the pelvic floor muscles. Abbott et al. Performed a double-blind randomized controlled trial in patients with chronic pelvic pain that was published in the Green Journal in 2006. 30 women received 80 units of Botox injected into the pelvic floor muscles, and 30 women received saline injections. The results demonstrated a significant decrease in VAS pain scores for non-menstrual pelvic pain and dyspareunia in the botulinum toxin group. Interestingly, in the saline group, dyspareunia is also significantly reduced from baseline. In addition, they reported a significant reduction in pelvic floor pressure in the Botox group when compared to pre-injection values. An improvement in all measures of quality of life was demonstrated, with Botox producing greater benefit compared with placebo for nearly all parameters. Published in AJOG in 2019 is a double-blind randomized trial of women with myofascial pain who were randomly allocated to a pelvic floor injection of either Botox or saline. All participants then started 8 weeks of pelvic floor physical therapy 4 weeks after the injection. With regard to the primary outcome, there was no significant difference between the Botox and saline groups in terms of patient-reported pain on palpation of the most painful pelvic floor muscle at 2 weeks after the injection. Additionally, there were no significant differences in pain for any muscle group at 4 or 12 weeks. Despite this, a higher percentage of participants in the Botox group were more likely to report their overall pelvic pain as improved compared to those who received saline injections at 4 and 12 weeks after the injection. This was only statistically significant at the 4-week mark, however. Also in 2019, a multi-center double-blind randomized trial was performed to compare the use of botulinum toxin and local anesthetic injection versus local anesthetic injection alone for pelvic floor myofascial pain. 80 patients were included, with 40 randomized to each group. There was no significant difference between the two groups after 2 months. However, both groups showed significant alleviation of global pain. So as you can see, the previous randomized controlled trials demonstrate mixed results for the use of Botox, but several smaller studies demonstrate obvious benefit. Marissi et al. Enrolled 28 women in a prospective pilot study to examine the effect of Botox injections in women with high-tone pelvic floor dysfunction. These participants reported a significant improvement in pain symptoms. And in a retrospective cohort study of 31 women who received Botox injections for refractory myofascial pelvic pain, close to 80% reported improvement in pain, and the median pain with levator palpation was significantly lower than before injection. There's also a retrospective case series of women with myofascial pelvic pain that evaluated the effects of Botox plus concurrent myofascial release performed in the operating room under general anesthesia. Patients received 200 units of dilute Botox injected into the pelvic floor muscles, followed by transvaginal myofascial release physical therapy for 10 to 15 minutes. Post-treatment, patients had a lower average pelvic pain score and fewer trigger points, and 58% of patients noted an improvement in self-reported pain. And finally, a systematic review, which was updated in 2019, synthesized the evidence for the effectiveness of botulinum toxin injection to the pelvic floor muscles for treating pelvic floor myofascial pain in females. This found a statistically significant reduction in patient-reported pain scores at 6 weeks after Botox injection and continued past 12 weeks. Significant improvement was also noted in secondary outcomes, including dyspareunia, dyskesia, and quality of life. In the previously mentioned studies, participants who received botulinum toxin did not have more adverse events than the placebo group, but it should be noted that side effects of Botox include bleeding at the injection site, mild flu-like symptoms, urinary or fecal incontinence, and constipation. These side effects do resolve as the Botox wears off. So I'm going to flip back over to my other screen. And talk to you a little bit more about the injections. So these injections can be performed in the office or in the operating room setting. And you'll need a disposable pudendal block tray, which includes a 10 milliliter controlled syringe, a 6-inch 20-gauge needle with a 1/4 inch spacer. And lastly, the trumpet, which allows us to protect our finger against a needle stick while we're injecting. In order to perform this, we remove the spacer to allow for deeper depth of penetration into the muscle. We attach the syringe, and then we place the trumpet. The pointer finger is placed along the tip of the trumpet with the needle protected, And once placed against the desired injection location, which in our case is the pelvic floor muscle, the needle is advanced into the muscle. And as usual, we aspirate the syringe prior to injecting to make sure we're not in a blood vessel. So here we will demonstrate the injections on the cadaver model. So with a finger in the vagina placed against the trumpet, we advance the needle into the pelvic floor muscle. And for the purposes of this video, you can see the needle, but in actuality, the vagina will be flush against the muscle and the needle will go directly through the vagina and into the muscle. This is us injecting the obturator internus. Ultimately, our patient underwent trigger point injections with Botox and found significant pain relief for approximately 6 months. She plans to undergo repeat injections as needed, in addition to intermittent pelvic floor PT sessions. So we're coming to the conclusion of the talk here, and here are the real take-home points. Myofascial pelvic pain is a common contributor to chronic pelvic pain that may present alone or coexist with other medical conditions, including things like endometriosis. Patients may present with a variety of symptoms, not just pain. They can also have urological symptoms, gynecologic, or GI symptoms. A musculoskeletal exam is an important part of the evaluation for chronic pelvic pain and should be performed by a specialist who knows how to perform the exam thoroughly. Data is limiting for the various treatment modalities, and finding the right combination for the patient is often individualized. There can be a lot of trial and error with different medications until the right combination is found. There is evidence to support a role for botulinum toxin injections for pelvic floor myofascial pain, and we look forward to seeing what else comes out in the future regarding Botox injections to the pelvic floor. And here are my references. And at this time, I'm happy to take any questions.
Well, that was just amazing, Dr. McKee. Such a very incredible, thorough presentation. And I'm a pelvic PT. So I feel like the fact that we were talking before we logged on, you're a surgeon. Surgeons, we always feel like to cut, but this is a new paradigm in thinking about pelvic pain, is that we have to think about the whole person and all the drivers of pain. That was just a phenomenal discussion. I want to welcome Dr. Yee. Dr. Yee, do you want to just quickly introduce yourself to everybody before we have our discussion?
Sure, absolutely. Thank you. I'm sorry I was late, everybody. I was in the operating room. I just got out. But I did hear Dana's talk, Dr. McKee's talk, actually, when she gave this to us for our didactics, and we spruced it up for this group as well. So it was a great talk. I agree that I think this is a really important talk in terms of our patients with chronic pelvic pain. Oftentimes we see these patients with endometriosis that we're operating on, but as Dr. McKee had presented, there's so many other confounding factors and so many other contributors that we have to address as well. We have to treat the whole patient, not just endometriosis, but the whole patient and all the sources of pain. So, you know, I think this was very comprehensive. I was very proud of Dr. McKee in her preparation for this and her presentation as well. I thought it was amazing.
Well, it's just incredible. I don't think I've ever seen that. I mean, I've been a PT for a very long time. I don't think I've ever seen cadaver on the pelvic floor. It was just incredible. I really hope so, like the endometriosis summit for sure, because our mission is really to teach that it's not just about surgery. But for sure we'll pick you up. But I really hope that other societies begin to embrace a presentation like this, because Also, the research was phenomenal with it. We have some questions from Instagram, but before that, the little pelvic PT in me has some questions. In my clinic, one thing that we try to educate patients about is that it's not do the Botox or do the trigger point injection and then go home. That ball in the muscle fibers has really happened because there's both spasticity and weakness. And if you don't sort of balance both of them, then you're just going to get the ball right back. What are some of the ways that you educate a patient about that? Or like Dr. Vidali and some of our other surgeons, do you leave that to the PTs to do that patient education?
I think I'll say a couple words and then let Dr. Yi take over. I think that the PTs are instrumental in this whole treatment process. And so while trigger point injections may help and cause relief of pain, if that trigger point needs more work with the pelvic floor physical therapist, then they may need ongoing sessions. And we do kind of let that be determined by the evaluation with the physical therapist. But yeah, I think ongoing pelvic floor physical therapy should just be kind of an expectation for the patient that that's something they may need to continue for a prolonged period of time.
And I always say, I had to really explain this on Instagram this morning. Pelvic PT isn't just someone sticking their finger inside your pelvis. It's really just like the surgeon, somebody treating you from the neck to the feet. Sometimes you're even doing cranial work, but I think it's super important. Now, we also try as hard as we can to avoid the Botox because there are side effects to the Botox. And even if it means multiple rounds of the trigger point injections, what is your feeling on trying to or having to use less Botox would be our ultimate goal if we have to go there. What is your feeling on, do you try to avoid the Botox, or do you, I know you presented an amazing outline here, but in your own practice, have you seen bad side effects from the Botox?
So I have not personally, but Dr. Yi has had a lot more experience with the Botox. So I would love to hear what he has to say. But Botox really is the last line. So we say that that is for refractory myofascial pelvic pain. That's not relieved with any of the other modalities that we may have tried. Oftentimes, just doing the trigger points with a local anesthetic actually does provide very good relief for patients, and they can continue those, you know, over a certain period of time. But if they're finding they need to have the injections closer together or that the relief is not what it once was, then we might take the next step forward and say, let's give Botox a try.
On your trigger point, I never get somebody that wants to talk south. This is like my language. So all the fans are asking questions and I'm asking first. On the trigger point injections, do you start with lidocaine and the steroid, or do you do a couple rounds of using an anti-inflammatory mixed in there, like a Trameal?
So we usually just start with the local anesthetic, but you know, depending on the setting too, where we're doing the procedure, if it's in the office versus the operating room, we could certainly add a steroid as well. Dr. Yi, what are your thoughts on that?
Yeah, I try to be careful with steroids. Over injection of steroids can lead to muscle wasting, and I've seen that in other parts of the body as well for my patients that have gotten injections. So I'll usually do the local anesthetics, maybe add a steroid, and then move forward to Botox after that. But I really do encourage them, and this is really a partnership with the patient and the physical therapist. And it's our job. We may be able to put the order in for a consult with physical therapy, but if we don't give the patients the understanding as to what's going to happen in that physical therapy session, I find that to be a big barrier because they may never show up. They may not show up, or they may say, this is way above my head. I'm not interested in doing this. So I do think it's important for us to educate the patients as to what goes on in PT. And as you said, it's not just a finger in the pelvis to do the myofascial release. A lot of this is deep breathing. A lot of this is that, like the diaphragmatic breathing. Some of this is work on the abdominal wall as well. So I think it is really important for the patients to understand the whole approach to the rehab along with the injections. And I usually encourage patients to try to set up their PT sessions after the injections if it's possible, to try to get the injections so that the PTs can work a little bit more in that area as well.
Right. So when I started working with Dr. Chung, we traveled throughout China and he would basically anesthetize their pelvis. And then I would go in within the next 30 seconds and the results were amazing. So I was excited to see you present that somebody's actually looked at that in terms of research. So I wonder, Dr. Vidali, who is my partner in crime, got called into the OR this evening. He has started to induce his surgeries with laparoscopic tap blocks. So he starts all his surgeries in the hopes that that shuts down that central nervous system connection and also that gripping in the abdomen as people are trying to recover. Do you see people who are doing that have less trigger points in their pelvic floor after, or you still look at them as totally separate entities?
I don't know that we've seen enough of that here.
Well,
Have we
come
been doing
here.
much, Dr. Yee?
I think some of the randomized control trials looking at tap blocks for laparoscopic hysterectomy have not shown that much of a difference. But I think that's and part of that is because the patient selection. We haven't seen a lot of studies come out specifically in the chronic pelvic pain or endometriosis population specifically. So if you take all comers, it may not make that much of a difference. But we do. I utilize tap blocks in patients that do have abdominal wall trigger points, and I've also do the trigger point injections in the pelvic floor at the time of their endometriosis surgery if they have myofascial pain as well. So, and we can use the Expro, which is a long-acting medication, and that does last a little bit longer. I'm hoping that that will be a little bit better from perioperative standpoint. We don't have studies to show that, but anecdotally, I have been utilizing that for my patients to try to get them some pain relief around surgery as well.
Right. So that's what we're using as well. And so I hope those studies are on their way, because when somebody goes to a big center like ours or like yours, they can get that kind of care. But I want that kind of care to be available everywhere. Right. That's the goal. We have a couple questions. I know I could talk about this forever. We have a couple questions that came in off of Instagram. Then we have a few floating around from everywhere else. But Dr. McKee, when we put up our graphic on having a myofascial pain night, the first question that came up was, is TMJ related to myofascial pain in the pelvis? And I have my own opinion after working in the field, but I'd love to hear what you have to say.
I think that they certainly could be related. I think a lot of TMJ2 is exacerbated by poor sleep. Something is happening during someone's sleep where their muscles, in the jaw and around the face are not relaxing. And honestly, that same type of mechanism can happen in the pelvic floor muscles and can be part of the reason people get trigger points or have, acute pain flares. And so I do think that those are probably very related conditions, and I would not be surprised to see both of those conditions in the same patient pretty frequently.
Right. So we've been looking at the research on heart rate variability and sleep in chronic pain patients. So we have to have a whole night on that, but it made me so happy to see you talk about sleep. I can say in the pelvic pain world, we talk about how the tissue in the mouth and the tissue in the vagina embryologically develop at the same time. And so they kind of always have this connection the rest of your life, both in pleasure and in pain, unfortunately. And so if you're somebody who grips in your pelvic floor, you're also going to grip in your jaw as well.
Mm-hmm.
I have also seen, like studies on that pelvic floor people. There's somebody who mapped out each individual pelvic floor muscle and does it mirror which each individual mouth muscle. They didn't really say why in that study, but there are some connections. And then I would also say, if you're a clencher, you're clenching your pelvic floor too. So all of that Dr. McKee talked about relearning how to hold yourself, so important.
Mm-hmm.
Yeah. I had a question from Facebook that asks, how many sessions should you go to PT before you go back to your doctor and think about the trigger points? And that's a hard one. I have my own answers because I think, well, who is the PT and what skills are they using? But I wonder, in your opinion, how many sessions before they go back to the doctor?
I think that that can probably be really variable. I'm sure many patients do a full, 4 to 8 sessions before going back to seeing their doctor. But one thing that can happen is doing concurrent trigger point injections. Like Dr. Yee said, even before the physical therapy, to help really get the most out of those sessions by already having some of those trigger points, hopefully a little bit more relaxed or desensitized, to help with the myofascial release.
I think there's a great connection of those trigger point injections because of the lidocaine that's usually in them to also down regulating the central nervous system pain. What do you think?
Yeah, I think that there's definitely that I would agree. I think that that mechanism is definitely taking place, and is an option that can be presented to patients. We are talking about the diagnosis, you're talking about treatment. Physical therapy is definitely first line and something you're going to do, but whether or not you're going to do multiple modalities at once, you can talk to the patient and kind of come up with a decision together regarding what will be best.
Yeah, so somebody was watching your presentation on Facebook, and especially when you were talking about what it sort of is like to have a spasmed muscle, and the question became, can they have these spasmed muscles without even knowing about it? Because then I think it becomes incredibly important what you do, which is to teach everybody to check for these. But are patients always aware of these spasms? Like, do you feel it contracting?
They may not always be aware, kind of going back to the TMJ thing and something like teeth clenching or teeth grinding, people might not be aware that they're doing those types of activities. And people who are doing that may not develop myofascial pelvic pain, but it is certainly a risk factor if they are repeatedly spasming and causing tension in those muscles that trigger points could develop.
I
Yeah, I
agree.
do.
I
Go
do
ahead,
think that
doctor.
sorry to interrupt. I do think that that's important. I think a lot of the patients may, while pain is a big red flag, and that's what most of our providers and colleagues treat. A lot of times these patients will also show up with different types of symptoms: urinary urgency, incomplete emptying, recurrent UTI when their cultures are all negative, bowel dysfunction, and this sense of, I need to go to the bathroom. I get there and there's really nothing that I need. Nothing needs to come out. So I think the innervation in the inside of the body is very different than the innervation on the outside of the body. When you have a Charlie horse, you know exactly what that is. You can tell what that is. But when you have a heart attack, oftentimes you may not know the difference. So I don't know that patients always are aware, hey, I have a spasm in my pelvic floor. And that's something that we have to educate patients on in terms of what we can find on their physical exam.
And the other thing too is that it can be referred to other locations. So they may be having a pelvic floor spasm, but they're coming in with abdominal pain or back pain. So that's just something to keep in mind as well.
I think it's so fascinating. We had a conversation with Dr. Yaniv Lariche, who is the urologist most of the Endometriosis Summit uses here in New York. And he talked about how much rectal pain he really sees driven by aftershocks from the bladder because of the nerve innervation, and how many patients come and beg for rectal resections. And he just says, hold out, let's back up. Let's look at your nerves. Let's look at your pelvic floor and see what else is going on. We have a question from here on Zoom, and it's about vaginismus. You didn't talk specifically about vaginismus tonight, but the person wants to know, what do you do if pelvic PT is scary? So you have an awareness that it's muscular and you need help, but what do you do, and how do you educate a patient that pelvic PT doesn't have to be scary?
Right. Yes. And that definitely points to the patient education by the physician or provider who sees them. The pelvic floor physical therapists are amazing, and they're incredibly professional, and they help patients who have all kinds of difficulties, including things like vaginismus. Something that may be helpful that I did touch on a little bit that the patient could do prior to their session is use the vaginal diazepam suppository. That might help relax some of those muscles and help for the session to be more comfortable or at least less uncomfortable. So things like that, or using topical lidocaine before the pelvic PT sessions can also be helpful. So I think just a little bit of education and comfort in addition to possibly some medications can help with those sessions. Even oral or systemic medications could be taken before the first couple sessions as well if there's a lot of anxiety surrounding the session.
Yeah, the vaginismus population is even more cautious as they go into pelvic floor physical therapy. So, these are patients that have never tolerated anything in the vagina, not a tampon, not intercourse ever, and it's really important for them to understand what they're signing up for when they go to pelvic floor PT. And I often tell them, hey, they don't need to start with a pelvic exam at all. They can start with a history, just go talk to them, and then they can work on deep breathing. They can work on abdominal wall. When you get more comfortable, you can work towards the pelvic floor as you get there. But I think these are patients that may benefit from sex therapists as well, and just a really multimodal or multidisciplinary approach.
Right. So I always remind everyone, like 24 hours a day in my house, that pelvic PT is not always internal. So if you have vaginismus, there's plenty of progress that can be made without doing anything that's penetrative towards your pelvic floor. And then I was wondering while we were asking this question, I don't know what the laws are in Arizona, but tons of my pelvic floor patients and vaginismus patients are using medical marijuana or CBD suppositories, and they can be tremendous in the vaginismus population because they also have a little bit of anti-anxiety. What do you guys, I don't know what the laws are in Arizona, so I don't know if you can answer.
Well, I believe it is now legal in Arizona to use marijuana. I have not actually specifically had a patient or spoken with a patient who utilized marijuana prior to the pelvic floor PT session. I do imagine that it would reduce anxiety. Dr. Yee, have you had any patients who have mentioned this?
Yeah, we're seeing more patients on CBD and also just using medical marijuana as well. And, anecdotally, it does seem to have some benefit, although it's hard to know. I think because we don't have a lot of research on this, it's really hard to know the overall impact, whether this is anxiety related or if there's a muscle relaxant component to it. I think a lot of that, it would be great to have some research looking into these modalities, but it's hard for us to recommend, mainly because we just don't have a lot of studies based on it.
Right. So I should hook you guys up with the Go Love people because he's a guy that researches this also with Aspen Green. Those are both products that for the endometriosis summit they've given and we've tried, but the Go Love itself is a lubricant and you can use it on external genitalia. And so when somebody progresses to the point where they're able to try penetrative sex again, oftentimes that helps because obviously it has an anti-anxiety component to it. And we did have them speak and they did present a lot of research. I should see if I can get you the key that's in last summit. So I should see if I can get you that. And they're very interesting people because she was a sex therapist for a psychologist. I also will mention for people who are afraid of therapy and who are looking for the diazepam is amazing beforehand. There's also a product called Private Packs, and it's actually a hot pack or an ice pack, depending on how you use it, that you can put in your underwear like a pad. And so that can be very, very nice for relaxing the muscles, but also for providing different sensation into the brain, which you also need. And then let's not forget that Intimate Rose created for Endometriosis Awareness Month the pelvic wand that you can put in the freezer for cold and you can put in the microwave for hot. And you can use the code Sally and the Endometriosis Summit could get a little kickback if you really need that. So just saying that Sally gave up treating patients to run the Endometriosis Summit. So any money coming in would be good. Because we don't take pharma actually right now. I wonder, somebody is saying like, what do you have to do the vaginal Valium if you're going to go through to try to treat myofascial pain? What is your opinion on that?
No, you don't have to try that. Really, the variety of medications that I discussed, patients can try one or multiple of those medications. They can skip over one and to the next. If they have any concerns about the vaginal diazepam, definitely not required to move on to trigger point injections. So yeah, long story short, the answer is no, that is not a requirement.
Now, I exist in a world where this is common, right? This normal conversation. When you gave this presentation to your colleagues, other surgeons, was it brand new information for them?
No, I don't think it was brand new. I think, always doing a good review of the most recent literature might bring to their attention some articles they hadn't seen yet, or kind of update them on the latest and greatest. But I did present it to a group of surgeons. I am in a minimally invasive surgical fellowship. We all like to operate, and we do a lot of endometriosis surgery, especially. But I think that this topic is so important for our specialty that's why I chose it and chose to present it to all of the faculty in our department at Mayo Clinic in all 3 sites. And so just keeping this in mind for patients who continue to have pain despite endometriosis resection, continue to have pain despite treatment of a urologic disorder, definitely something to consider as myofascial pelvic pain.
Right. We had Dr. Dassel for the endometriosis summit, and he gave a presentation and he said this in that a surgeon wants to be successful. If they go in, they want to know that they're going to get the result that they need. And so sometimes you have to back the camera up, like the camera in your mind, not the actual laparoscope, and really think of the person as a whole, because if you don't, you're not going to get any progress. And so work like this, like Dr. McKee presented tonight, it's not about first you have an excision and then you didn't get better instantly. So then you go find some other amazing excisionist and you go again. Do you find treating the myofascial pain helps avoid repeat unnecessary surgeries?
I think that varies. I think that some people do need repeat surgery for their condition, as an example, endometriosis. That disease component can certainly be a contributor of pain. And the hard part is distinguishing if it's one or the other, or is it a combination of both? So I think if someone does have obvious myofascial pelvic pain on an exam, who's going to have endometriosis surgery as well, letting them know that you'll probably need pelvic PT, whether that's before and or after surgery, can kind of already help make that expectation that they're going to need multiple treatments for their pain.
Actually, before I wrap up, you brought up a good point. Pelvic PT before or after surgery, or both? What do you like, doctors?
This is a great unanswered question. I actually wrote a grant for it to study it in a randomized controlled trial and couldn't get it funded, unfortunately. So yes, that's the reaction I had as well. But we don't have the answer to that. Is the endometriosis causing the spasm of the pelvic floor, or is the pelvic floor a separate entity that you need to treat itself? And I think there's different ways to think about that. I take the approach of saying these are 2 entities, and these are the different treatments that you need. You need a good surgery for endometriosis or adenomyosis. And then afterwards, as you're recovering, your pelvic floor may not know how to relax anymore because it's been in that spastic state for so long. So then you may need pelvic floor PT for this separate diagnosis that you have. They may be truly separate. So we don't have a clear answer to that. If we have the ability to get in with pelvic floor PT before surgery, I think patients learn a lot about their pelvic floor and learn a lot about function, and can improve their rehab just in general, just as much as going to a pelvic floor PT even before a vaginal birth may have some benefits there as well. Again, we don't have a lot of evidence for that, but I do think that they can learn a lot about their pelvic floor and learn how to engage their core, how to relax their core and their pelvic floor muscles. And I think I can only see benefit to that.
Dr. McKee, your opinion, pelvic floor before or after, both?
Completely agree with my mentor, Dr. Yi. I think that if they can do it before surgery, that would be phenomenal. Oftentimes we get the patients and we book them for surgery fairly quick, so that might not always happen. But I do think, seeing these patients back, knowing that this could be a chronic condition. Just taking out the endometriosis might not be enough. And I'm going to see you again, and we're going to keep working through this. If you do still have pain, we'll go from there.
I find as a pelvic PT, I really like patients to do it before if they can do that. It depends on their schedule, their finances, and everything else. But before and after, that before component, is it going to solve all your pain? No. Is it going to provide a different input to your brain? It might. It may help you identify what is muscular and what could be the endometriosis. It also helps you as a person identify your own floor, your own core, your own breathing pattern, so that just having recognition of that stuff, you can begin the healing when you go home. Because a pelvic PT, unless you're lucky to have like maybe Sally in your surgery, a pelvic PT isn't really going to start from anywhere between 2 to 4 weeks. So I like that before, because it's like almost like pre-programming the healing. Yeah. I'm upset about your research. You know, our goal one day is to fund research. We're working on one study now, but and actually don't hang up when I turn the recording off, because I have an idea for you. But don't you know, one day we'll fund your research, you know, because that's a super important one. Anyway.
I agree.
Perfect.
So as we close out tonight, we're running just a little bit over. I want to thank Dr. Yee and Dr. McKee, who had this amazing presentation. Dr. McKee, I have rarely seen something so comprehensive on myofascial pain at any of the conferences. So I feel like the Endometriosis Summit is one up today. I hope that when we hold Endo Summit surgery as part of our big conference, we can get Dr. McKee to come back, because if we don't, our patients know to ask for it many times, but I think it's time to teach our surgeons really why we need to treat myofascial pain. And I want to just say thank you so much. Somebody's looking for the recording already, Dr. McKee. That's a good sign.
Oh, that's great.
Our recordings sit on our YouTube channel, Endometriosis Summit. It usually takes 2 to 3 days to get up there. But you can see all of them up on our YouTube channel. So go and subscribe, because then you'll get a notification when it launches. Thank you, everybody. You want to tell everybody good night, Dr. McKee?
Yes. Thank you so much, Sally, for this opportunity. Thank you for those who have tuned in. And I look forward to hopefully being more involved with Endo Summit in the future.
Yeah, it was awesome. All righty. We'll see you guys soon.
All right. Thank you all.